behalf of Department of Ilmul Kabalat for Amraz Niswa and Bangalore, I, Anya Khan, welcome you. A warm welcome to all of you joining us today on this webinar, National Thyroid Awareness Week. Thyroid Awareness Week serves as a critical platform for us to raise awareness, share knowledge, and foster dialogue about an issue that is very common. It almost affects millions. Throughout today's session, we aim to dwell complexities of thyroid disorder, discuss strategies for the concepts of she has authored Am I audible now? Yeah. Hello, Pura Sundari madam. Hello, am I audible now?
To some extent.
Yeah, madam, please share your screen, ma'am. So I welcome Professor Sundari madam to share her knowledge regarding thyroid dysfunction in pregnancy.
Everybody, at doubt, am I audible? Am I audible?
Yes, ma'am.
Yeah. At the outset, let me thank you all for inviting me to share my experience on thyroid complicated pregnancy. Moment we hear the word thyroid, everybody gets depressed. It's such a common thing, so many times discussed. What is there new about it? Again, at the same time, there is so much of confusion whether to treat or not to treat. Is there any problem you are not treating or you are over treating? And you also know as practitioners, the moment patient comes as a thyroid levels are high, she starts crying, "Mujhe thyroid ho gaya." It's nothing to be scared. Only thing is you have to treat it properly so that the correct levels are maintained. Nothing will happen either to the baby or to the mother. Greetings from the KIMS hospital where I'm working. And today we are going to discuss about the management of thyroid disease and the management guidelines. What's the main problem? Thyroid is what is the issue? Is there really a problem? What is the gravity of it? What should you do? Where is the confusion? Are there any guidelines? There are definitely guidelines are there. If you follow them, you will be very safe and the patient will be in better hands. So by definition, it is the second most common endocrine disorder next to diabetes. And our India, especially South India, is the diabetes. It is the threshold of diabetes, and next is the hypothyroidism. In this T3 T4 are decreased, TSH is increased, and if it is high, it goes to myxedema. But coming to hyperthyroidism, in this T3 T4 are increased, TSH is decreased, and thyroid storm may also occur. Thyroiditis is an autoimmune inflammation, postpartum period, usually hypothyroid stay within 1 year. Thyroid crisis is there when acute T3 T4 raise is there. And Graves' disease is autoimmune again condition, TSH binding inhibitory to immunoglobulins. This typical picture of hyperthyroid lady, she looks cute and very nice, but she is so pale. Is the typical thing you can make out patient is must be hypothyroid. So it's a more common primary thyroid dysfunction. It may be secondary to radios, iodine, surgery, hypothalamic abnormality, Hashimoto's thyroiditis, the long-term disease, or acute thyroiditis, and may be seen in iron deficiency also. The contrast that is hyperthyroidism, where typically the eyes are all bulging out. That is called exophthalmos, and here it is called Graves' disease. Multinodular goiter may be there, toxic edema, and when the patient is having hyperemesis gravidarum, not getting treated, routine treatment, you should always think of hyperthyroidism and estimate the thyroid levels. So, trophoblastic disease, when patient is having here also, patient may present with hyperthyroid features and viral thyroiditis, exogenous thyroid hormone. So primary hypothyroidism is associated with increased odds of preeclampsia, gestational diabetes, preterm labor, birth induction, cesarean section, ICU admission. And iatrogenic hypothyroidism was associated with placental abruption, breech presentation, cesarean section, and hyperthyroidism was associated with preeclampsia, superimpulse preeclampsia, preterm birth induction, ICU admission. And we all know the incidence is increasing. We have been in the practice for the last 40 years, but now, it is the incidence is increasing, and you can see normal thyroid function test is seen only in some 80%, but you see almost up to 9% of patients will suffer hyperthyroidism. 40 million people in India suffer from thyroid disease. Congenital hyperthyroidism, most important, 1 out of 264 neonates. So it's very important that you check the thyroid levels in all patients who are already on thyroid treatment. Subclinical hyperthyroidism is seen in 1.6. Overt hyperthyroidism was present in 1.3. More than third of community detected hyperthyroid cases have positive anti-TPO antibodies. So initially, they come with hyperthyroidism. Ultimately, they end up in hypothyroidism, and then they end up permanent hypothyroidism. The prevalence, if you take trimester wise, hypothyroidism 15%, and is 12% is there in the, and 14.3% are seen in the anti-TPO antibodies 18, 19, and 22. So 44.3%, 32% and 34 women are found to have hypothyroidism in the first, second, and third trimester respectively. So T4 is circulating, T3 is periphery. T4 is controlled by TSH, as you all know. TSH receptors are almost same as LH and HCG. So LH and HCG are increased in the first trimester. So you may find, though everything is normal, you may find the TSH levels to be less because of the competitive inhibition. So having TSH low with normal T3, T4, you should be cautious. Don't start any treatment. You can repeat the TSH levels at 14 to 16 weeks. Usually you found it to be normal. Hence, free T3, T4 measurements are accurate and alteration of T4 levels occur. TSH hypothyroidism, 4 milliunits. So you want it to be around 2.5 to 3. It is very difficult to remember all these things. You blindly remember that it is 2.5 to 3. First and second trimester maximum should be 2.5, and the third trimester maximum should be 3. It is Phe3/4 are decreased in subclinical, and 2.3 apparently normal pregnant have low TSH. 3.5 them have overt hypothyroidism. Anti-thyroid antibodies are raised in 50% of the patients. So why this happens? Pregnancy demands thyroid levels change. 6 to 8 weeks, T4 and TBHG increase and remain high. HCG from placenta thyrotrophic activity, so TSH and T4 are reduced. So low TSH and thyroid binding globulin are physiological. That's what I told you. When you see 0.2 or 0.1 of TSH in the first trimester, don't get perturbed and don't start the patient on treatment. Usually you have to repeat the TSH levels around 14 to 16 weeks. Usually they revert back to normal. So in the first trimester specific, if you think 0.1, 2.6 is first trimester, 0.2 to 2 points is again in second trimester, 0.3 to 3 in the third trimester. In case twins, of course, you have more HCG levels, so you have lower HCG. The fetal effects, fetal have thyrotoxin axis dependent on maternal thyroid. Iodine concentration end at 12 weeks is increased. So pituitary TSH here 20 weeks is very ideal. Human placental barrier at T3, T4, TSH is there. The IgG, AA, and TRH antibody medications cross the placenta. So physiological changes, increase renal clearance, decrease plasma 1 and plasma transportation to the fetus, increase oxygen consumption of the fetal placental unit. First time it increase of HCG, increase serum TBG, increase plasma volume, inner ring deoadenization of T3, T4 by placenta. So this is equals to increase 24 of this thing, and one deficient woman decrease T4, increase TSH and goiter formation. So increase BMR, increase T3 and T4, decrease basal thyroxine levels, increase total T3, T4. So if you find levels high and TSH very low in the first trimester, just be cautious. Repeat the test around 16 to 18 weeks. Usually they revert back to normal. So the first trimester TSH is reduced due to increased HCG. Renal iodine clearance is decreased because the glomerular filtration rate, and T3 uptake is there. So T3, T4, normal free T3, T4 are very important. What happens if there is hypothyroidism? Patient will complain of constipation. As such, in pregnancy, patients have constipation due to progesterone levels. But in the hypothyroidism, you have more cold intolerance, dry core skin, irritability, delayed tendon reflexes, and very grave cases you have mixed. So when you give the lab test, TSH is raised, T3, T4 are decreased, anti-thyroid antibodies are increased. If you are untreated, what happens? It can lead to infertility, abortions, preterm labor after pregnancy, preeclampsia, postpartum thyroiditis, thyroid crisis. So it is our aim is to maintain TSH between 2.5 to 3 in mainly international units per ml. So T4 should be replaced with levothyroxine because it has a long life, only single dose in the morning, empty stomach, and for next 10 to 15 minutes, ask the patient not to take anything because that will act with other drugs. So long life is there, you need only OD dose, and it should be given in the morning only. Mainstream TSH is 0.5 to 3. TPTS every 4 weeks, the first half, and 28 30 weeks to adjust the dose. Continue postpartum at 6 to 10 weeks, look for PPT. So what is the treatment to give? There are so many studies that have been there. So white paper includes compelling studies indicating that by making universal thyroid screening mandatory, all pregnant women, India may further bring maternal child deaths, bring down the maternal childbirth. Bring about the policy intervention which will impose maternal and fetal health scenario in India, reduce social economic consequences. See, I tell you, the thyroid tablet is very cheap, hardly it costs 5 to 10 rupees. But if you don't treat, the consequences are very high. So doing one test of thyroid TSH levels in the first trimester, you can pick up the patients who are having hypothyroidism and treat them with thyroid. With 100 tablets will hardly cost 50 rupees. So that will definitely save both the mother and the child. So it is very important to check for the TSH and treat the patient so that the social and economic burden on the society and the patient is decreased. So in the key highlights of the white paper is misplaced public health focus. India is the thyroid capital of the world. Thyroid care is economical. The cost of thyroid screening ranges from just 100 to 700. 3-month therapy costs only 100 to 125. So loss due to untreated hypothyroidism during pregnancy may leading to miscarriages, abortions, may lead to crores. So congenital hypothyroidism situated in India is alarming. Abnormal high rates of 1 in 8 neonates against the average of 1 in 3,800 neonates of hypothyroidism. So 11 to 25% pregnant women have hypothyroidism or subclinical hypothyroidism. Less than a quarter of the pregnant women are screened thyroid, and so it should be made a point that all patients you should be universally screened in the first visit when they come to us for diabetes and thyroid, and if it is low, put them on thyroxine, and this hardly costs any amount. The thing is, patients are um, somehow they are perturbed, saying that thyroid aa gaya, so I'm having some this problem. So I may be there are patients this are so innocent. They've been even divorced because they are having thyroid problems. So it is important for us to consult the patient, consult the family, and tell that it's a small tablet which will help both the mother and the child. So if you treat the hypothyroidism in pregnancy, anemia can be treated, preeclampsia can be treated, placental abnormalities are there, low birth weight infants, postpartum hemorrhage, myopathy, and in neonates, if you see the the bilirubin to be high, even after 9th or 10th day, even when there is no ABO incompatibility, you should think of hypothyroidism, because when the mother is having hypothyroid, there is delay in the in metabolism of the bilirubin, so patient will have hyperbilirubin. So the recommendations are OH should be treated in pregnancy with levothyroxine. All women with trimester-specific increased TSH at low T4. All women with TSH more than 10 irrespective of T levels. Isolate hypothyroxine and TBAG positive should be treated and associated with adverse effect on mother and fetus. Women with TPO antibodies should be treated. So it is very imperative when the TSH levels are high. One more test, that is the thyroid globulin, TPO antibodies, if you do, that will tell how worse the condition is. The TPO antibodies are high. This needs patient to be treated seriously. Don't neglect the patient. And reference level should be aimed and available with caution. TSH estimation with trimester and method-based range should be preferred. So hypo recommendations is OH already on treatment, dose individualized and adjusted. So it's a known hypothyroid in pregnancy, definitely the amount of thyroxine she is needing will be increased. So you have to see the TSH levels and increase the TSH dose for the patient every 4 weeks for first half and 26-32 weeks the second half. Folic delivery, the TLT4 dose should be reduced. And all should be treated with pregnancy with levothyroxine. All women with trimester specific increased TSH low TF4. All women with TSH more than 10 respective levels, isolated hypothyroxemia, EBAG positive should be treated, and associated adverse effect of the mother and fetus should be thought of, and you have to treat the patient. So you have to see if the patient is having anemia and development abnormality of the baby and congenital hypothyroidism. So coming to iodine deficiency, which is more seen in places where the patients are in the high altitudes, they have got iron deficiency. They may come with goiter or cretinism. So iodine-rich food for hypothyroidism is very important, like iodized salt, seaweeds and seafoods, saltwater fish, sushi, nori rolls, and Celtic sea salt. This may not be available in high altitudes. Selenium-rich food for hypothyroidism like meat, chicken, salmon, tuna, and whole unrefined grains, drizzle nuts, and dairy products, garlic and onions. So for vegetarians, you have got milk and Brazil nuts and dairy products and onions and garlic, which are very important managing the hypothyroidism. Minimum 250 micrograms required per day in pre-pregnancy. Iodine salt to be the best source. Pharmacological exposure to be avoided. Sustained intake of dietary iodine 500,000 milligrams daily is to be avoided. It can cause fetal hypothyroidism. During this thing, lactation, all patients with postpartum depression should screen for thyroid problem. TSH and FT4 TPO antibodies should be tested. So they may be having normal levels, or you may be seeing them for the first time in the postpartum period. So it's always important to the patient is having depression or a subinvolution, and our patient is having this thing postpartum problem. You have to estimate the TSH, pre T4, T4 antibodies. Thyroid toxicose phase, beta blockers are used, propranolol in the low doses. Antithyroid drugs are not recommended. Following resolution, TSH tests every 2 weeks till 1 year. Hypothyroidism, asymptomatic, only TSH 1 for 48 weeks. Symptomatic or pregnancy is planned in the near future. Start levothyroxine and dose slowly tapered. Past history of PPT or TAB positive, but euthyroid only observe TSH monitoring should be done. In pregnancy, universal screening is not recommended. In euthyroid patients, no evidence of for or against. In screening TAB or treating with ALT, and in previous pregnancy loss, preterm labor, prior IVFs, it is important for you to screen for the thyroid levels. So, it is very important for you that though thyroid is a very simple thing and you manage with very low dose cost of treatment, and you have to be very vigilant, and a simple test in the first trimester by treating her with just 0.25 to 50 milligrams, which is very cheap, which they can afford. It is less than 1/10 of even iron capsule. It will save both the mother and the fetus. So there are some consensus. All pregnant females should be screened at first antenatal visit by measuring TSH levels. Both maternal and fetal hypothyroidism is known to have serious adverse effects on the fetus. Subclinical hypothyroidism has been shown to be associated with an adverse outcome for both mother and offspring, and hence should be treated with before. Diagnosis should be based on trimester-specific TSH. That's what I told you. First trimester, second trimester less than 2.5. Third trimester should be less than. So first trimester is 1 to 2.5, second trimester 2.2 to 3, and in third trimester it will be 0.3 to 3. And thyroxine requirement increases by approximately 30 to 50% during pregnancy. Adjust the dose every 4 weeks in early pregnancy, preferably in the first trimester itself, so that euthyroid state is reached. Free T4 and TSH level should be tested every 6 weeks. And if patient diagnosed with overt hypothyroidism during pregnancy, start therapy with full replacement dose of T4, that is 1.6 to 2 micrograms per kg per day, to normalize the thyroid function test as rapidly as possible. So if you treat the patient properly, premise-specific reference range are maintained, and patient will have a good output both for the mother and the child. So whatever you treat and whatever you see, the challenge is development of time-specific reference range, human as a platform, geographic area of study. See, why I'm saying that is, we got a TSS done in one lab just 2 days back that showed almost 13.5. So we got scared and we got them to repeat that comes as 3.5 in the same lab. So you have to be very careful when you're sending it for the testing, and you have to again cross-check with and age, ethnicity, body mass index, disease variants, multiple pregnancy are to be considered. Difficulties in obtaining a disease-free population for TSS sampling, and even when the same immunoassay system is used in carefully designed protocols, we experience in this. So, universal screening not required? Yes, it has required. Past system hypothyroidism, thyroid dysfunction, family history, goiter, TAB positive, type 1 diabetes, previous miscarriage, preterm labor, another autoimmune disease, infertility, especially IVF, morbid obesity, past history of head and neck irradiation. This required contrast medium is definitely hard to do. But otherwise, also I say in India we have to. It is a very cheap test, and you can rule out the problem with very minimal expenditure. So serum TSH during pregnancy using pregnancy-specific references is very important. About hypothyroidism, elevated TSH, decreased T4 concentration. TSH levels are more than 10, irrespective T4 levels, you have to treat them with drugs. And subclinical hypothyroidism, TSH 2.5 to 10 and normal concentration should be maintained. So using non-pregnant reference ranges, hypothyroid women could be misclassified during pregnancy using being euthyroid. So euthyroid pregnant women could be classified. The conclusion is thyroid disease were associated with obstetrical, labor, and delivery complications. These nationwide data suggests there is a need for better thyroid disease management during pregnancy, or that there may be an intrinsic aspect of thyroid disease that causes the poor pregnancy outcomes. Undiagnosed hypothyroidism in pregnant women may lead to adversely affect their fetuses. Therefore, screening for thyroid deficiency during pregnancy is warranted. And the prevalence of hypothyroidism are 44, 32, and 34 in the first, second, third trimester respectively. The hypothyroidism can cause preeclampsia, eclampsia, gestational hypertension, placenta abruption. The long-term complications in the mother, including postpartum hypertension, lactational problems, impaired neuropsychological intellectual development, and postpartum psychosis. Autoimmune thyroid disease can increase the incidence of preterm labor. Meta-analysis can recommend that universal screening for not missing detection of partner by pregnant women with thyroid dysfunction is recommended. And most of the guidelines do recommend estimation of the TSH in the first trimester. So, white paper launched by the FOST and Sullivan in collaboration with the FICC suggests government authority to facilitate universal spreads and make an essay. When you say you get the TSH done, patients start with kabhi nahi tha. So kabhi nahi hua hoga, ma just get it done once. At least it rules out that you are not having a problem. So it sometimes becomes very important to consult the patient and get the treatment. So your target should be in the first and second trimester less than 2.5, the third trimester is less than 3, and with that levels maintaining with the drugs, patient will definitely have a better fetal-maternal outcome. Thank you.
Thank you, madam, for enlightening us with your wisdom. Now, I request Professor Arshia Sultana, madam, to present tribute to Dr. Sundari, madam.
Hello, good afternoon. I'm audible to all.
Good afternoon.
I'm audible to all.
Yes, ma'am.
Yeah,
Yes,
I'm
ma'am.
thankful to madam for giving this lecture. I'm able to see that madam is not feeling well, though she has joined us. So this is tribute to our teacher and mentor, Professor T. Sundari madam, because she is not only teacher of myself, but Dr. Ismat madam and as well as Professor Vajja madam. We cannot express enough gratitude for guidance and support. Your wisdom has been invaluable to us. Thank you for being an incredible mentor. Your advice and insights have been instrumental in our personal and career growth. We are deeply grateful for the time and efforts you have invested in mentoring us. Your guidance has been a guiding light in our career. Thank you for your unwavering support and invaluable advices in time to time. We are truly fortunate to have you as a mentor. We are immensely thankful for your mentorship and the positive impact you have had on my life and career. Your wisdom is a treasure to us. Thank you for being such an inspiring and dedicated mentor. Your guidance has shaped our journey in ways we never imagined. Whatever today we are because of your mentorship. Your mentorship has been an extraordinary journey of learning and growth. Thank you for being such a remarkable mentor and teacher for us. Once again, my thanks for your patience, wisdom, and encouragement. Your support and guidance have been a pivotal part for our professional journey. We are really thankful to you, madam. Always in front of my student, I take your name, saying that we have learned from you.
Thank you. Thank you so much.
Thanks a lot, madam.
The continuous learning is the one which makes us, keep updated with the subject. Yes, so by doing such lectures, we again go back and read, which makes us, up to date.
Thanks a lot, madam.
Thank you.
Shall I leave?
Anya, madam. Continue. Thank you, ma'am. Thanks.
Next speaker, Dr. Fatma Firdaus, madam, is currently working as an assistant professor in Kabalat wa Amraz and Iswa, National Institute of Unani Medicine, Bangalore. She has a teaching experience of 13 years and has worked in 8. Ma'am has published 45 research.
Madam, take complete.
Ma'am is the author of 4 books. Ma'am has reviewed 15 theses. Ma'am has been a thesis reviewer for 15 theses online and has been online journal reviewer. Ma'am has been PG examiner for 4 batches and resource person for 17. Ma'am has attended and conducted more than 200 CMEs, attended 28 workshops and 30 training programs. Thyroid disorders in gynecology.
Assalamu alaikum and a very good afternoon to all. At the outset, I thank the Director, National Institute of Unani Medicine, and our department for organizing, and the organizing chairperson, Professor Arshia Sultana, and organizing co-chairperson, Professor Wajiha Madam, for giving me this opportunity. Today, we spoke to a very senior professor about thyroid dysfunction in pregnancy. So, I'll be speaking on the second part of the OBG, that is gynecology, thyroid dysfunction in gynecology. Is that audible? Visible? Sorry.
No, ma'am.
Abdi.
Yes, ma'am, it is visible.
Is it visible now? Hello?
Yes, ma'am. Yes, ma'am.
Visible?
Yes,
Okay.
ma'am.
So we'll be dealing with the thyroid dysfunction in gynecology. Thyroid disorders affects nearly 15% of the adult population and are among the most common endocrinopathies in the reproductive age women. All of us know that females are more prone, or they come with more complaints of hypothyroidism, because female sex appears to be an independent risk factor for thyroid dysfunction, as women are 3 to 5 times more likely to be treated for thyroid disorders than men. Thyroid disorders affect female reproduction in a pleiotropic fashion. Both direct and indirect impacts on various levels of the female reproductive system, starting from the hypothalamus to the ovaries and the uterine endometrium. As all of us know, the thyroid gland is a butterfly-shaped gland located just below the larynx. The follicular cells of the thyroid gland secrete the thyroid hormones. The thyrotrophic releasing hormone initiates the cascade of the HPT axis. The thyrotrophic releasing hormone triggers the secretion of the thyroid stimulating hormone from the thyrotropic cells in the anterior pituitary, which in turn stimulates triiodothyronine T3 and tetraiodothyronine T4 secretion from the thyroid gland. Transport of T3 and T4 throughout the body subsequently facilitated by high specific plasma proteins such as thyroxine binding globulin, transthyretin, as well as albumin in the bloodstream, and they carry these hormones to the thyroid sensitive cells throughout the body. In addition to the effect of effect on the thyroid stimulating hormone, the thyrotrophic hormone has also indirect effect on the GnRH, because as TRH increases, in addition to the effect on TSH, it also increases the prolactin, and this prolactin increase indirectly inhibits the GnRH secretion. The mechanism underlying this effect of hyperprolactinemia on the central components of the HPG axis are complex and multifactorial, and we are all aware of that. Before moving on to the dysfunction of hypothyroidism, I would like to discuss few points related to the physiology of thyroid hormones on the human systems. Thyroid hormones affects almost all systems of the body, maybe it musculoskeletal, nervous, maybe respiratory, circulatory, digestive, integumentary system, or reproductive system. For example, in circulatory system, it is required for maintenance of the heart rate, force of contraction, stroke volume, and maintain the adequate cardiac output. Whereas in respiratory system, it is useful in increasing the resting respiratory rate. It is useful in increased ventilatory response to hypercapnia and hypoxia. It is useful in neuronal development, increased wakefulness and alertness, increased memory and learning capacities related to the thyroid hormones. It is also required for the normal emotional tone. The speed and amplitude of the peripheral nerve reflexes is also maintained by the thyroid hormones. When we come to the musculoskeletal and integumentary system, it is required for the muscles growth and sustenance of the bone strength, moistness of the skin, hair growth, and maintenance of eyebrows, particularly the lateral eyebrows. Whenever patient comes off disturbances or falling of eyebrows from the lateral side, it should be a pointing towards hypothyroidism, and we need to evaluate it accordingly. So also it affects the digestive system as it is associated with maintenance of appetite. Good thyroid secretions will have good appetite. The secretions and movements of the gastrointestinal tracts are again dependent on the thyroid hormones. There is including, it is required in protein synthesis and glucose metabolism. Not only so many systems, it is also hugely required for the maintenance of reproductive system as it is required in the metabolism and development of ovarian, uterine, and placental tissue. It is also required directly involved in the normal follicular development and ovulation, and it is required for the maintenance of pregnancy. As all of us know that GnRH triggers the release of LH and FSH from the gonadotrophins in the anterior pituitary to act on the theca and granulosa cells in the ovary, to stimulate the synthesis of gonadal steroidogenesis and peptides as well as ovarian folliculogenesis. Thyroid hormones such as thyrotrophic hormones, thyroid stimulating hormone, T3 and T4 perform facilitatory roles at each level of HPG axis. The TSH is a in addition, the TSH is a glycoprotein that shares an alpha subunit with LH and FSH and has been implicated in actions on FSH receptors. TSH receptors also have been observed in human follicular cells. Furthermore, TSH causes proliferation in the endometrial tissue in women. T3 appears to reinforce here you can see the T3 appears to reinforce neuroendocrine regulatory effects of the TRH by independently suppressing prolactin. Can you see the arrow? By independently suppressing the prolactin synthesis in a dose-dependent manner, in addition to affecting inhibiting hypothalamic neurons through gonadotrophin inhibiting hormones. The female reproductive system, the female reproductive tract relies on the gonadotrophin, sex steroids, and several other endocrine and paracrine factors to facilitate ovulation, fertilization, implantation, and gestation. Beyond their effect on upstream estrogen production and transport, thyroid hormones appear to play a direct role in supporting the development and maintenance of the female reproductive tract at the level of the ovary, uterus, and the endometrium. In addition to the hormonal interplay, as we just discussed in the previous line, it also leads to direct effect on the organs, reproductive organs like the uterus, ovaries, and the fallopian tubes. Coordinated hormonal regulation of the ovary is critical for folliculogenesis and the production of gonadal steroids. In human oocytes, the cumulus cells and the granulosa cells have the expression of the cumulus cells and granulosa cells have the expression of the thyroid hormone receptors in addition to the presence of thyroid hormone per se in the follicular fluid. This supports a direct role of thyroid hormone on ovarian dysfunction. Thyroid hormone stimulates the proliferation and reduces the apoptosis of the granulosa cells by potentiating FSS-mediated cell survival pathways. Expression ovarian, as all of us know that ovarian matrix metalloproteinases are responsible for the disintegration of extracellular matrix. Expression of these matrix metalloproteinases is mediated by the thyroid hormones. With such multifaceted effects of the thyroid hormones on ovarian function may account for the observed association between thyroid disorders and infertility. At every level, beginning from the production of the hormones to the release of growth of the follicles and release of the follicle through ovulation, at every level, thyroid hormones are imperative. In addition to this, the The key components of the uterus are the myometrium and the endometrium. The thyroid hormone receptors are expressed in the human myometrium and endometrium. The thyroid hormone receptors are present in the human myometrium and endometrium in addition to the receptors of the estrogen and progesterone. This provides a plausible avenue for the observed effects of TSH on uterine function. Thyroid hormones are known to mediate an endometrial proliferation as well as facilitate uterine contractions. Furthermore, thyroid hormones appears to facilitate endometrial decidualization, that is conversion of the normal stromal cells to secretory cells, and prevent immunological rejection of the embryo, which is critical for implantation. Even in the next step, if you can see, moreover, in the event of unsuccessful, even after decidualization, if the patient is not pregnant and if the decidualization fails, implantation fails, even in the event of unsuccessful implantation, thyroid hormones may help mediate endometrial shedding in the ovaries through menstruation. Association between thyroid hormones and menstrual cycle characteristics are well documented. They appear to be mediated by the effect of thyroid hormone on estrogen and progesterone levels. At the level of the fallopian tube, this was about the ovary and the uterus. Even at the level of the fallopian tube, there is a bit difference in the effect of thyroid hormone. The effect of thyroid hormones is variably different depending on the developmental changes. The fallopian tubes, when studied in animal models, it showed that the effect of thyroid hormones is more prominent in the post-pubertal period as compared to the prepubertal period. T3 and T4 mediate transport of gonadal steroids through their effect on expression of the sex hormone binding globulin. TSH has the impact on estrogen and progesterone through its effect on sex hormone binding globulin. Hormones mediate an indirect regulatory effect on sex hormone binding globulin through hepatic factor 4A. This relation of thyroid hormones and sex hormone binding globulin is demonstrated by elevated sex hormone binding globulins in hyperthyroid subject and reduced sex hormone binding globulin in hypothyroid subject. Consequently, also we see serum in urinary estradiol levels correlate highly with circulating T4 in reproductive age women. Importantly, the associated effect of TH on estradiol levels appear to be bidirectional. As estrogen receptors are expressed broadly throughout the thyroid tissue, a high estrogen level stimulates the thyroxine binding globulin expression and secretion. In addition to this was about the normal physiology of the thyroid hormones on the female reproductive system. When we speak of the thyroid dysfunction, how do we get to know that it is a thyroid dysfunction? We go to do a thyroid test. Usually we advise a thyroid profile having T3, T4 and TSH. In euthyroid and a normal thyroid states, all the T3, T4 and TSH are normal. In an hyperthyroid state, the TSH being low and T3 and T4 on a higher side. In hypothyroidism, the T3 is normal or low, T4 is low and TSH is on higher side. These are the normal ranges of the TSH, T3 and T4 along with T4 and TSH 0.4 to 4 milli-international unit per liter. Total T4 5.4 to 11.5 micrograms per dl. Free T4 is 0.7 to 1.8 nanogram per dl. Total T3 80 to 220 nanogram per dl. And free T3 is total T3 is 80 to 220 and free T3 260 to 480. So based on these values, we have to differentiate what is the type of thyroid dysfunction we are facing. We said primary hypothyroidism, secondary hypothyroidism, primary hyperthyroidism, subclinical or clinical, depending on the free FT4 and thyroid stimulating hormone. For example, if the FT4 is high and the TSH is low, it indicates primary hyperthyroidism. Primary hypothyroidism, on the other hand, if both the FT4 and TSH are high, it indicates secondary hypothyroidism. Now coming to the impact of thyroid dysfunction in females. I hope all of you have understood the effect of physiological effect of thyroid hormones on female reproduction. Coming to the impact of thyroid dysfunction on females. It might be because of hypothyroidism or hyperthyroidism. In hypothyroidism, we come across anovulation, amenorrhea, hypermenorrhea, prolonged cycles followed by heavy menstrual bleeding. Patient will be complaining of cycles every 2 to 3 months or even 6 months. Whenever the patient reads, the bleeding was to nearly a month or so. So patient will also facing issues with fertility, galactorrhea because of the concurrent increase in the prolactin in case of hypothyroidism, wherein TSH is elevated. It also leads to endometrial hyperplasia. There's a high association of hypothyroidism with polycystic ovarian disease, and patient also complains of intermenstrual bleeding. When we come to hyperthyroidism, patient more often complains of hypermenorrhea, amenorrhea, oligomenorrhea, and infertility. In the subsequent slides, we will see how these symptoms are the mechanism of these symptoms in the light of the hormonal interplay. As all of us know, this increase in in hypothyroidism, there is rise in TSH hormones and reduction in T4 and T3. Rise in TRH and reduction in T4 and T3 jointly has effects on the increase in the prolactin levels. This increase in prolactin levels indirectly suppresses the GNR, inhibits the secretions from the GnRH. What does the GnRH secretes? It is the FSH and LH, thereby causing interruption of the pulsatile secretions of the LH, leading to anovulation. Increase in TSH along with the TPO antibodies positive is a high indicating risk factor for fall in AMH. I will be studying that in the further slides. Reduced AMH with anovulation leads to infertility. On the other hand, increased prolactin also reduces the sex hormone binding globulin levels. Once the sex hormone binding globulins levels decreases, there is increasing in free circulating estrogen. This free circulating estrogen in the absence of progesterone because of chronic non-ovulation leads to endometrial hyperplasia. This endometrial hyperplasia causes amenorrhea because unless and until there is no withdrawal progesterone priming, there is no estrogen primed endometrium progesterone is contacted, there is no periods. So we'll be having amenorrhea, prolonged cycles followed by HMB, irregular shedding because of the endometrial hyperplasia, and irregular bleeding, intermenstrual bleeding. And if there is a prolonged unopposed estrogen, that might lead to the increased risk of endometrial carcinoma. On the other hand, chronic anovulation can lead to polycystic ovarian disease and infertility. I have come across few studies of systemic reviews and meta-analysis wherein premature ovarian insufficiency is highly correlated to autoimmune thyroid disease, AITD. What happens in here, irrespective of the thyroid hormones, if the TPO antibodies are positive, then you have to rule out you find a concurrent premature ovarian insufficiency. Autoimmunity is apparent in autoimmune polyglandular syndromes where there is a high prevalence of autoimmune endocrine destruction. Holding premature ovarian insufficiency and autoimmune thyroid disease, there may be additional effects of thyroid hormone abnormalities on ovarian physiology, as thyroid hormone have effects on granulosa cells and upstream components of the hypothalamo-pituitary gonadal axis. It means to say that TSH might be elevated, but that is coincidental rather than autoimmune destruction of the glandular tissue. Maybe it a thyroid gland or the ovary causes destruction of the ovarian cells leading to premature ovarian failure. So also association between polycystic ovaries and autoimmune thyroid disease is noted. There is 3.3 odds increase in the incidence of polycystic ovarian disease in patients diagnosed with autoimmune thyroid disease. I also endometriosis. The endometriosis is also an independent factor arising in relation with the positive antibody, TPO antibodies. If the TPO antibodies is positive, irrespective of the thyroid gland, there is a concurrent presence of endometriosis up to 2.7 odds increase in cases of endometriosis cases in case of TPO antibodies positive. In other few studies have shown that the severity of the endometriosis is directly proportional to the level of TSH levels. As the TSH levels increases, means the more severe the hypothyroidism, the more impact will it put on the endometriosis. However, the autoimmune factors are solely responsible or more responsible for the premature ovarian failure and endometriosis rather than TSH per se. No doubt, TSH will cause an additive effect in increasing the symptomatology in such conditions. Coming to the effect of hyperthyroidism on the female reproductive system. Hyperthyroidism means there is an increase in the thyroid hormones T3 and T4. With the increase in T3 and T4, they cause subsequent increase in sex hormone binding globulin. This increase in sex hormone binding globulin means there is no free circulating estrogen. No free circulating estrogen causes no circulating estrogen. There is no endometrial proliferation. There will be endometrial atresia, or endometrial thickness will be below 5. And this loss of endometrial proliferation will lead to hypomenorrhea, amenorrhea, or prolonged cycles like oligomenorrhea and infertility. Endometrial and growth of endometrium is crucial for the implantation. So wherever there is a deficit in the endometrial proliferation, there are implantation problems associated. On the other hand, increase in LH causes follicular atresia or premature luteinization. Again, that leads to no ovulation leading to prolonged cycles, hypomenorrhea, and infertility. If all these conditions, hypothyroid conditions, are not treated timely, it leads to complications like increased risk of heart failure in hypothyroidism, coronary artery disease events, mortality from the coronary heart disease, anemia, infertility, osteoporosis, peripheral neuropathy, and depression. Because thyroid hormones, as discussed in the very earlier slides, thyroid hormones have impact on almost all the systems of the body. On the other hand, if hyperthyroid is not treated, it leads to atrial fibrillations, thyroid storm, osteoporosis, decreased fertility, menstrual irregularities, dermopathy, arthropathy, and increased mortality. Coming to the Unani concept, all of us know that the base of the Unani concept is based on the 4 humors. So here we classify the thyroid disorders under Swemisaja Parid Madhi of the Balgham. Of the 4 akhlaq, what we have done, Balgham, Safra, and Sauda, the thyroid disorders in Unani, the increase is attributed, hyperthyroidism is attributed to the Swemisaja Har Madhi of the Safra, called as Kasrat Ifraz Darqiyya. And in Swemisaja Barid Madhi, it causes reduction in the secretion of the thyroid gland, that is Khillat Ifraz Darqiyya. So the causes attributed to Khillat Ifraz Darqiyya or Swemisaja Barid Madhi, or use of internally or externally moist medicine, use of murattibat, zofigabid, ghair tabi balgham, or if the patients are used to sedentary lifestyle, they are continuously using murattib hamam, diet with excessive water content, alteration of asbab sitta zaruriya, excessive intake of food, or murattibat. Symptoms of, here you can correlate the concepts of Swemisaja Barid Madhi and symptoms of hypothyroidism. They are almost the same. Like for example, there is hair fall, there is cold intolerance, there is lethargy, khabs, tahabbuj. You can just correlate most of the symptoms what have been described under the heading of Swemisaja Barid Madhi are the same symptoms what have been presented, what the patients of hypothyroidism presents in the clinical practice. For example, loss of appetite, loss of libido, excessive sleeping, dry and coarse skin, hair fall, diminished intellectual functions, bradycardia, ascites, among others. As a sequel, Swemisaja Barid Madhi, in addition to infertility and amenorrhea, can also cause obesity and recurrent pregnancy loss because of the formation of Suddha in the uterine vessels. And zofigabid adds on to the causation of amenorrhea and other complications. How do we manage hypothyroidism? As all of us know, the principles of management, we have to start with dietotherapy, then regimental therapy, then ilaj with dawa, and the main concept of the treatment is ilaj with zid. And as we discussed earlier, if any derangement in asbab sitta zaruriya, the problem arises, the problem of Swemisaja arises. So you have to correct the asbab sitta zaruriya using relevant diet, drugs, and regimens. Diet should be hot in diet used in hypothyroidism should be hot in temperament and Jayadul Kaimus, Latif, and Sariul Hazm. Consumption of ghizai kasif or khalis such as beef, rice, idli, dosa, junk foods, maida products should be avoided. Of the regimental therapies, whatever increases the metabolic rate, For example, in general concept, we see the basal metabolic rate goes down in cases of hypothyroidism. And all these regimens given in the Unani classical text under the heading of Swamisaja Madhi basically increases the BMR, thereby helping out in case of pathophysiology, reversing the pathogenesis of hypothyroidism or Swamisaja Madhi. It might be through diaphoresis, exercise, steam bath, emesis, maybe diuresis, purgation, cupping, venesection, or leech therapy, as and when appropriate. A single or a group of 2 or 3 regimens can be incorporated in the treatment of hypothyroidism. It is not necessary that we advise a patient all of the regimens. Any combination of 2 or 3 regimens with adequate appropriate diet and drugs will be helpful. In pharmacotherapy, again, with the concept of ilaj bisid, we have to use drugs of har yabis misaj depending on the requirement of the patient. If the patient maybe diuretic drugs, immunogogue drugs, expectorant, we might use demulcent, we might use cardiotonic and stimulant drugs along with hypertonic, ishale jigar, because there is often zofe jigar associated with Swamisaja Barid Madhi. So on the line of basic line of treatment is use of for Swamisaja Barid Madhi is use of Munsij Musil therapy. You can use any of the Munsij Balgham Nuska followed by Musil Balgham. The most commonly used one is Mawez Munakha, Naudana, Badian, Panchmasha, Aslasus Mukhashar, Satmasha, Persyavish Hunt, Satmasha, Anjir Sar 2 adad, 4 tola Gulkhan ke saath. Decoction is prepared and given to the patients. This is followed by Musile Balgham using Mawai Munakha 15 number, Unnab, Sabistan, Sufa Khush, Gule Banafsha, Persya Oshan and Badian in 9 grams and Anjir Khush 7 adad. With or without Maksai Malta, Turanjabin and Rohane Badam Shirin. So there are also other drugs recommended for hypothyroidism depending on their properties. Those include Mukhil, Asgan, Kachnal, Barge Sehajna, Brahmi, Zira Safed and Zirasia. In our day-to-day clinical practice, we have been using the compound formulations like Majune Mukhil, Safufe Muhazil, Habe Asgan, Habe Mukhil, Itrafile Khudadi, Majune Jogra Jugal, Majune Sarax, and Majune Saras for the treatment of hypothyroidism. When we speak of the treatment of hypothyroidism here, we should not abruptly stop the levothyroxine if the patient is on and suddenly start with our medication. It is a gradual interchange of treatment, or we can basically start the treatment in subclinical cases rather than affluent cases of hypothyroidism. This evidence-based research on Majuna Falasifa and Safuf Akhar Kharha, Ahmed et al. Used 3.2 grams of Akhar Kharha with 10 grams of Majuna Falasifa per day for 45 days had shown improvement in TSH levels in hypothyroidism. This was a single-arm study. Similarly, Majune Sarkhas, Alam et al. Used 10 grams of Majune Sarkhas with levothyroxine for 60 days had shown more improvement in TSH levels than in levothyroxine alone. Here, 2 groups were taken. One group only levothyroxine was given, and other group levothyroxine plus Majune Sarkhas was given. The improvement was improvement in TSH was better in the Majune Sarkhas with levothyroxine group as compared to levothyroxine alone. Similarly, Saiduddin et al. Conducted a study on Jadwar at a dose of 2 grams per day for 56 days, improved TSH levels as compared to the placebo. And similarly, Barge Sehajna, Shabnam et al. Conducted a study on Barge Sehajna 3 grams per day in the form of capsule for 45 days, shown good improvement in TSH levels than placebo. Coming to the hyperthyroidism, that is Kasrate Ifrase Darqiyya and Unani system of medicine, the causes are implicated to Khair Muftarat, use of internally or externally hot medicine, alteration of Asbab Sitta Zaruriya and Musakin Fiza. Here, it is to be noted here that any alteration in Asbab Sitta Zaruriya causes different sort of diseases, and our rectification through the regimens and diet should be done accordingly to restore the Asbab Sitta Zaruriya. As discussed earlier in the hypothyroidism, even in a hyperthyroidism, the symptomatology is same in case of Swamisaja Har Madhi with that of hyperthyroidism, that include insomnia, lack of concentration, anxiety and tremors, excessive sweating, heat tolerance, weight loss, increased appetite, tachycardia, palpitation, hyperactivity, among others. So how do we manage with this? Diet should be cold in temperament. As I said, it is a concept or principle of Ilaj Visit. Diet should be in cold temperament. More of ashijo, goat milk or shirebus should be given. Shirebrans, that is rice pudding, palak and kurfa are recommended. In pharmacotherapy, Barid Ratab Misa Advia with Muaddil or Dafai Safra like Imli, Ananas, Turanjabin, Alu Bukhara is etc. are given, and others we can make symptomatic treatments. As for the lack of concentration, for anxiety and tumors, Majun and Naja proves to be a very effective treatment in cases of anxiety, palpitation. For we can use amla, preparations of amla for increased appetite and palpitation, and even for palpitation we can go on with Fursa Kafur, with Khamira Sandal Sada, Sharbate Sandal Murakkab and Sharbate Nilofer 2 tola each. These all medications should follow the protocol of Munsis Musil of Safra. Then we have to give symptomatic treatments as required. Other single drugs recommended for hyperthyroidism, that is Kharija Safra, Adviyan, Biranjasif, Badranj Boya, Sankaholi, Sharifa, Asrol, Bale, Bargerihan, Methi, Amla, etc. To summarize the thyroid dysfunction on female reproductive system or gynecology, it have almost effect on every part of the reproductive system, from the ovary to the uterus, uterine myometrium, endometrium to the fallopian tube to the ovulation. As I have summarized, in hypothyroidism, there is decreased proliferation of the endometrium, reduced uterine weight, reduced endometrial thickness, reduced endometrial glands, reduced decidualization that is leading to infertility, and antioxidant mediators are reduced, and their infundibular epithelium is also reduced. Whereas in hyperthyroidism, there is increase in weight, increase in uterine epithelium, uterine thickness, myometrial thickness, uterine vascularization, and increased ampullary epithelium. So, to conclude, thyroid hormones have significant effect on all of the reproductive system. Timely screening and appropriate management should be a norm. Thank you. These are the references.
Thank you, ma'am, for sharing such a wonderful knowledge. It was very enlightening. I request Professor Arshia Sultana, ma'am, to present token of gesture to Dr. Kausar Fatima, ma'am. I encourage all of you to actively participate in the discussion and ask questions or share your experience, if any. You can post your question in the comment section, or you can just ask it by raising your hand or something. Any questions from the audience, please?
Ania, let them
Either
unmute
raise your
themselves and ask the question. Okay. There are some questions in the chat. Dr. Kausar, let her answer it. So Dr. Shima has asked one question. In which category of hypothyroidism normal T3, T4 and raised THS comes? Dr. Khalal, do you like to answer the question?
Hello?
Dr. Khalal, there is one
Yes,
question
ma'am.
from Dr. Shima. In which category of hypothyroidism normal T3, T4 and raised TSH comes?
I have just shown in the slides, maybe she had joined later. Normal TSH raised T3 and T4, it's a overt hyperthyroidism wherein the thyroid gland is hyperactive. Overactive thyroid gland leading to hyperthyroidism. Can you make out on the screen? Here.
Second question is from Zakira Begum. Most of the hypothyroid patients present with HMB without prolonged cycle. What is the pathophysiology there?
There's increased proliferation of the endometrium there. Increased proliferation of the endometrium.
Dr. Abhi has asked the question. All the studies discussed included established cases where they have subclinical hypothyroid. So whatever the evidence you
Clinical
have given,
hypothyroidism, wherein the levels of TSH are low, below 10. We can try our medications. Whenever we are doing a research drug, we cannot give a research trial on the full-fledged thyroid cases by stopping the active levothyroxine what they are taking. Initially, we have to take the milder cases. If we have good effect on that, then we can add on along with levothyroxine, do studies, then replace the levothyroxine with whatever the research drug is.
any other questions? Dr. Anisa has asked, is there any Unani management for thyroid dysfunction?
I have just discussed through the slides all the managements. In addition to the Munzij Musil, depending on whether it is hypothyroid or hyperthyroidism, along with the dietary regimens and the regimenal therapies, whatever have been discussed here, maybe cupping or diaphoresis, depending on the case, you can give at least those drugs which have already been done preliminary research on. We don't have full-fledged RCTs and meta-analysis systemic reviews, but whatever available RCTs, we can take help with them and benefit the patients.
Any other doubts? Any other questions from the audience? So any other questions? Dr. Abhi, you like to ask any question?
Yes, ma'am. Can you hear me?
Yeah, we can hear you.
Ma'am, my question is again for Kaushal, ma'am. Ma'am, since she's mentioned that you cannot take an established case, but you could take a mild hypothyroidism case to do a randomized control trial. Ma'am, I just wanted to know because many times we plan a study over here and we get people from the medical college. What I mean to ask is the people from the modern medicine, they say that we do not categorize hypothyroidism as mild, moderate, or severe. We basically, based on the values, we basically say that this person is hypothyroid and requires medication. But since ma'am mentioned that the milder cases could be given the Unani medication. So what is, ma'am, what is your thought on that?
Here we are not categorizing hypothyroidism and mild, moderate and severe. Rather, we are telling subclinical hypothyroidism and hypothyroidism. So whenever you are beginning this research with, we can use with subclinical hypothyroidism. If you are willing to do it on the frank hypothyroidism, wherein the values are more than 10, when the patient is already on levothyroxine, in such cases, you cannot completely stop the medicine. Instead, as I described in one of the studies, you can reduce the dose to half plus your medicine, and in the other group, you can give the full dose of the levothyroxine and look for the effects.
Yes, ma'am, that we can do. Otherwise, ma'am, it would be like you are
ethically
or not.
Tell me.
Because ethically, if you will stop the medication, it will not be ethically right.
Considerations with the ethical issues only I'm speaking. You cannot totally stop the levothyroxine. You can reduce the levothyroxine dose to maybe calculated dose, maybe 50%, 75%. plus add-on therapy as ours, then you see the effect. Then gradually
Okay, ma'am.
studies and you can, or in the same patient, if the patient is responding well, not a single patient, when a group of patients is responding well, then dose dependent manner you can change.
Okay, ma'am. Thank you.
Dr. Qasim, one more question is there
Ma'am,
from Dr. Shima. She has asked, is it possible to avoid neonatal hypothyroidism when mother has a history of hypothyroid?
neonatal hypothyroidism is usually congenital. Early detection and timely management is all that is required.
One more question, as Dr. Zakir has already asked why there is HMB in hypothyroid. She is asking if hyperproliferation of endometrium is under hypothyroidism. So common symptom are amenorrhea there. So kindly clear the doubt of HMB due to hypothyroid.
Sorry, ma'am, I did not get.
See, she's asking if there is because she asked why hypothyroid cause HMB. You said it is
Yes.
because of hyperproliferation of
Hyperproliferation.
endometrium. Is common under hypothyroidism. So common symptoms are amenorrhea. She's saying hypothyroid will cause
Yeah, in that
amenorrhea.
case, we have also to rule out other ovarian pathologies associated, because whenever we speak of thyroid hormones, there are other problems like PCOD coexisting. So the pathologies may. Hello.
Yeah, we are audible. You are audible, sir.
Hello. If such pathologies coexist, then the clinical presentation might be different. If the patient is having coexisting anemia, if the patient is having coexisting PCOD, then the symptomatology varies. We are not focused in, if we are speaking only of the patient with hypothyroidism, the scenarios will be different. More often what we come across is the hypothyroidism patients will be having associated other disorders, maybe PCOD, like we explained about endometriosis, or in long-standing cases, there'll be even anemia. So depending on all those symptomatology, it presents.
Dr. Zakira, what you have asked is that the patient may have HMB and amenorrhea. That is right. In early phases of hypothyroid, the patient will have heavy menstrual bleeding because initially it will cause hyperproliferation. But as the patient becomes chronic hypothyroid, the patient will develop amenorrhea. So in initial stages, because of this dearrangement, because we have seen there is a role of leptin, there is a role of estrogen, progesterone having connection with the TSH hormone. So in early phases, they will be having heavy menstrual bleeding. When newly detected cases of hypothyroid, usually they may present with history of heavy menstrual bleeding, but as they become chronic, they may develop amenorrhea. And Dr. Abhiya was just asking, because yesterday also we had a CME program in our institute concerned with thyroid dysfunction in females. So as she highlighted, shall we go for research? So yesterday we came to know that if the patient is having, non-pregnant patient is having TSH less than 10, there is no need to give any treatment, but she needs follow-up. Because subclinical hypothyroid doesn't need treatment if this patient is not pregnant. I'm not saying about pregnancy. It is non-pregnant patient. If suppose she gets levels below between 5 to 10, usually we should not start thyroxine. We have to wait. We have to reevaluate the patient. If suppose it is increasing more than 10, then we should give thyroxine. Like that, yesterday only we had a discussion in our institute. So this has come to highlight that usually in subclinical hypothyroid, treatment is not needed in a non-pregnant patient. For the guidelines, you can directly go for ACOG guidelines, Indian Thyroid Society guidelines, where you can see the treatment which can be, and again you can see that National Health Policy also have given guidelines how to manage hypothyroid during pregnancy. So these guidelines are easily available online, so you can just find it online. Any other questions? It is a hypothyroid and both are a topics are of research in females also. Usually we think it's a Molejar topic or we think it's a general medicine topic. But nowadays what scenario we are seeing in Bangalore is endemic to hypothyroid. So we are seeing more number of cases increase in hypothyroid, and usually we don't have a very good treatment in hypothyroid, or we do have treatment, but we are not able to give to patients because of lack of knowledge, or because we are seeing that there are more adulteration in drugs. What we are doing here, we are seeing the patients, we are continuing hormone replacement therapy to the patients. Along with that, we are giving Unani medication to improve the quality of life, because when the patient is having hypothyroid, she will develop vitamin deficiency, she will develop anemia. So what we are doing, adjuvant type of therapy we are giving to the patient. We are not totally stopping hormone replacement therapy, because we try to do that. We did in 2-3 patients that we said to, okay, you stop medication, you take only Unani, but there was no response with only Unani medications. Any questions? Shall we go for vote of thanks?
Yes, ma'am. It
Dr.
seems
Anya?
like all the questions have been answered. Okay, so I request Professor Arshia Sultana Madam to present vote of thanks to the speakers and the organizing committee.
Thank you, Dr. Anya. In the name of Allah, the most beneficent and the most merciful, I am deeply grateful to Almighty Allah for giving us this opportunity. As we conclude today's program, I would like to express my heartfelt thanks on the behalf of National Institute of Unani Medicine and our Department of Amraz and Iswan wa Ilmul Khabalat. We celebrated World Thyroid Day on 25th May 2024 and International Thyroid Awareness Week from 25th to 31st May 2024. Throughout this week, we conducted public health awareness programs, door-to-door campaigns, CME sessions, and a webinar on thyroid dysfunction in females. Today marks the final event of our Awareness Week 2024. I extend my sincere thanks to Professor Sundari Madam and Dr. Kausar Firdaus Fatima for the exceptional efforts in organizing this webinar, making it memorable and sharing valuable insights on thyroid dysfunction in women. Their ideas and clear explanations were greatly appreciated. I'm also thankful to our director for granting permission, motivating us to conduct such programs, and providing all necessary facilities. His vision and mission-driven leaderships are evident in all our institute's developmental activities. He is a catalyst that inspires us to do our best. I extend my gratitude to all the organizing members for the immense cooperation, and to the PG scholars for the enthusiasm, cooperation, and collective effort. I am short of words to express my appreciation for the involvement and the willingness to get beyond the comfort zone to complete this task. Finally, I would like to thank all the delegates for joining this webinar and everyone present here for taking the time to be with us today and helping us make this event a grand success.
I will
Thank
take
you
a
all
moment here,
once
ma'am.
again.
I will take a moment here with your permission.
Yes, of course.
So one of the messages, categorize endocrinal disorders according to Unani system of humors, then management should be made. Dr. Shahida Rahmani. Actually, we were planning for webinars on endocrinology because we are more not connected the concepts of the modern endocrinology on the body fluids of Unani system of medicine. Hope we'll plan for the webinars on endocrinology in near future, and hope you all participate. Thank you.
Thank you all once again, and let us join hands to work together for a better future ahead and to uplift our system, that is Unani system of medicine. Thanks once again.
Thank you for joining us and making this webinar a valuable and enriching experience for everyone. Thank you so much.
I request all the delegates to kindly fill the feedback form to get the e-certificate. I request all delegates to kindly fill the feedback form to get the e-certificate. If they won't fill the form, possibility of getting the e-certificate will be difficult. The link has been shared in the chat box. We are not closing the session. You can just copy the link of feedback and just fill it to get your e-certificate. I hope all the delegates had copied the link for feedback form. Shall we leave the session? Any doubts? Any clarification? Shall we leave the session? Yes. Just if you can open your videos, we can take a clip of your videos and we can save it that you have joined a program. I request all the delegates to kindly open the videos if it is possible so that we can take a snipping shot. If it is possible, they can open the videos. I request all the delegates to just open the video so that we can take a snipping shot. Most of the delegates have not opened the videos. I request all the delegates to kindly switch on the videos for a few minutes so that we can take a photo to save in our records. Thanks for your videos. Thanks a lot for your photos. So we will leave the session now. Thanks once again for joining us. And inshallah, we are going to do